good morning, good afternoon, and good evening, adjust accordingly to your time zone. My name is Chris Pell. I'm based at the Amsterdam Institute for Global Health and Development. Welcome to this Sonar-Global webinar. This is the first in the second series of events that we've held. Thanks for taking the time out from your day to join us. With a view to maintaining the flow of the webinar, we'd appreciate it if participants would switch off their videos and mute when not speaking. For those of you who aren't familiar with Sonar, just a little bit of a background. This is a global network of researchers and practitioners that seeks to marshal social science expertise on emerging and re-emerging infectious diseases and on antimicrobial resistance. We actually established in 2019 with support from the European Commission, and we have a core group of partners from across Europe, Africa, and Asia. You can find more information on our website, which is sonar-global.eu. If you haven't signed up yet as a member, I encourage you to do so. The sign up is on the top right-hand corner. You can see, although on that the screenshot there, it's actually already logged in, but it's where the little orange button is there. On the website, we have the slides and the recordings from the previous webinars. You can find those under the resources tab. This webinar will also be recorded, and we'll also put the recording on the website as well as the slides. So to today's webinar, well, this is, it's clearly a huge area. The social and economic implications of COVID and the response extend to almost every aspect of our lives and to most of the world. I'd therefore like to thank the speakers in advance for sharing with us their work in this area. I'm excited to hear from them. And each panelist will have 10 minutes to present. And this will be followed by 25 minutes of discussion time. If you've got any questions, please post them in the chat. I'll sort of organize the questions and then give the audience members the opportunity to ask them during the discussion period. So we have three exciting speakers for us today. We've got Dr. Gustavo Matta, who's a public health researcher at the National School of Public Health, FIOCRUZ Foundation, Brazil. He coordinates the Zika Social Sciences Network and the Working Group of Social Impact of COVID-19 at FIOCRUZ COVID Observatory. We have Dr. Phaik Yeong Cheah, who's an associate professor at the Mahidol Oxford Tropical Medicine Research Unit, where she leads the bioethics and community engagement team. Dr. Cheah also co-leads the networking work package within Sonar-Global. And I have Dr. Anthony Billaud. He's based at the Senegal at the Centre Régional de Recherche et de Formation. Within Sonar-Global, he's currently involved in developing training curricula around infectious disease outbreaks and antimicrobial resistance. So the first person who's going to talk today is Dr. Gustavo Matta. So I'd like to hand over to you, Gustavo.
Hi, Chris. Thank you very much for your kind introduction, and thank you for Sonar-Global to invite me to talk with you this morning from Brazil. It's very early here, but it's fine. It's a good breakfast to discuss with you. And a special thanks to Tamara Gilvernick, a very good friend and colleague. I will talk a little bit about some notes of narratives of COVID-19 vulnerabilities in Brazil. This is a kind of a provocative presentation to try to have different perspectives of how COVID-19 enacts in different countries and different contexts. So please, the next slide. Thank you. So I don't want to discuss the concept or the notion of vulnerability as we are using here as a kind of analyze. The more important to me, it's not to define vulnerability, but how social science, epidemiology, um, uh, public policies, health policies are using the term or the notion of vulnerability. That's why I am talking about nodes of vulnerabilities on COVID-19. So between mathematical models and social structure approaches or the social production of life, vulnerabilities enact different narratives, individuals, social groups and regions in active political and scientific process. This is important to say that I am taking the use of vulnerability not as a passive use, but an active use of process of vulnerabilization of groups and individuals. So many times epidemiological discourses say vulnerabilities as a counter effect or something that produce against some health threats, but taking it in a kind of a production of life, this is important to say that it is immersed in a kind of a social, economic, and cultural and political contexts. So COVID-19 unpacks the box of uncountable vulnerabilities, becoming the humankind fragile, mortal, and uncertain. There's a lot of unscientific uncertainties involved with COVID-19, but also impact the entire world uh, very strongly. So that's why it's important how humankind and social organizations and entire countries will respond in the now and in the future. This presentation pretends to share some notes on COVID-19 in an equal world. So please, the next one. I will start with some epidemiological narratives. As you can see, I don't know exactly where the audience is from, but COVID-19 in Europe, yes, you can say here, it's a kind of a peak of the epidemic, and now you can see a curve decreasing the number of deaths. I took the number of deaths as a more critical number of the epidemic that because we are talking about lives. And well, now you can see perfectly that it's a kind of wave. But now we are expecting a second wave in Europe of cases and probably new deaths. And our worry is about the collapse of the health system in Europe. So, but if you can compare with the next slide, please, we can see a complete different graphic here. So you can see a kind of mountain and a plateau in a high level number of deaths in America. Most of them are in the United States and in Brazil. So it's hard to say that we have a second wave, right? So if you can see here, many weeks in a high level of death. So the next one, please. I will focus now on Brazil statistic monitoring epidemiology. So, and then you can see the same here. So if you can go in the second slides about new deaths in Brazil, you can say an entire and big, as I usually say, a big tsunami, because we are talking now 4 months of more than 1,000 deaths per day. Brazil now crossed the line of 130,000 deaths until now. So the epidemiological curve here is completely different. Then we can say that in the epidemiological narrative, COVID-19 enact completely different epidemiological impact on different countries. Especially in different countries in terms of level of development or richest countries as US and Brazil. The next, please. The second narrative, epidemiological narrative, is a more socio-epidemiological narrative that I would like to share with you, is the lethality rate in selected favelas, slums in Rio. So now you can see here the lethality of one of the biggest favelas in Rio de Janeiro. You can see more than 45 lethality rates if you compare with the average of the municipality of Rio de Janeiro in the gray bar here in the bottom of the graphic. So the poor people is most affected by COVID-19 than other people living in the same city, if you can imagine different regions in the same city. So we are talking about poor territories, exclusion territories, territories of exclusions. So this is important to say that the impact in the same city is completely different. So the next one. So there's a lack of information about race and colors in the notification of COVID-19 in Brazil. In the black part of the circle, you can see almost 50% of no information about race and color. So why we don't have good information about this in a very unequal country, in a black country as Brazil? So more than 50% of our population is black. So why we don't have this information? And the black one, death, die more than white in our country. So the next one. And to finish the epidemiological narrative, you can see all the country in red, because we are monitoring in FIOCRUZ COVID Observatory, not just the COVID-19 notification, but the severe acute respiratory syndrome notification in our country. Then you can see here in the last week, all the country is in red. That's why that means that the notification of respiratory symptoms is very high in our country, more than the next year, much more than last year. The next. And then this is a comparison between some selected countries that you can see how Brazil is testing very few if you compare with the other countries. We are behind of Chile in South America, Cuba, Argentina, and other South American countries. So this is important to say that probably we will have more, much more than COVID cases notified, and much more deaths than we can imagine. The next one. So again, narratives of COVID-19 social vulnerabilities are making visible. One more time, HIV did the same thing. Zika outbreak did the same thing, especially to get visible. Um, um, okay, so that's 10 minutes now. Okay, I'm sorry. So let's talk about race and ethnicity, poverty and territories of exclusion, informal employments, precarious public transport and living conditions, and a lack of sanitation. So one important thing that I would like to highlight is the vulnerable territories are not passive. They are organizing themselves with social movements in favela, indigenous people movements, especially working through community health workers. The next, please. I will, unfortunately, I have to do it very fast. I'm sorry, I didn't count my time. So there's a lot of political production of vulnerabilities, like a lack of political coordination in federal, states, and municipalities. Please, can you jump in the next slide, please? And also production of scientific vulnerabilities. There's a very unequal structure of a scientific institution in Brazil and also in Latin America. And there's economic austerity affecting the financing of scientific institution and technology in our region. The next, please. And the question of national health system, we have a very, very good and structured a national health system in Brazil, the system, the unified health system. And we don't have a very good response to mobilize this structure during the pandemic. So we have lost a real opportunity to save lives during this period. The next, please. So I would like to say, my final words. So there's a narrative of temporality to conceive COVID-19 as one, but it is anachronic, diverse, multiple, and unequal. While Europe is starting second wave, Brazil is still suffering from a unique tsunami. COVID-19 enacts different realities, territory, and should produce different responses. Vulnerabilities as a hybrid, historical, and political phenomenon. The social isolation impacts different vulnerable populations, as you can see in my slide of the impact on favelas. COVID produced the re-emergence of risk group category and stigmatization of individuals and social groups. The risk groups category, it's a mathematical model. It's not a social model. So that's why how to prevent stigmatization of elderly people, people with comorbidity. So, and there are many issues involved with this. And then there are consequences, the naturalization of predictable death. And again, in Brazil, we are living a kind of naturalization of numberization of deaths. Is how to change deaths just in number, and nothing stops this kind of genocide in our regions. So, and the next one. So Brazil is burning now. And then this is a very important symbol that we can live. We are living in the entire world. And I would like to highlight this sentence. We can breathe, how we can change an equal world and an equal health system in this planet. So thank you very much. I'm sorry for cross my time. Thank you.
Thanks a lot, Gustavo. Yeah, that's particularly powerful. image and sentiment. I'm going to hand over straight away to the next presenter, and we'll take, please keep your questions for Gustavo, and we'll hopefully have some time at the end so you can put to him. Thanks a lot, Gustavo, again. And here's Anthony Billaud. The floor is yours.
Thanks a lot, Chris. So we will jump on other continents, like in Africa. So I'm working in the CRCF, in the National Hospital of Fan, and I'm also working for CRCF project, which is a coronavirus and anthropology in Africa, which is leading by Professor Alice Desclos. So I will talk about the socio-economic impact of COVID-19 in West African cities, with the question of collapse or resilience. So I have 5 parts, a short introductions. Then I will talk about the public health measures and the impact on vulnerable populations here. The assistance plans, what we call shielding activities, with the question of no one left behind. And then the resilience dynamics at local levels that we investigate. So next, please. So of course, we all know that public health measures for COVID-19 have strong socioeconomic impact at all levels, with exacerbation of social inequalities. The biomedical model of confinement and border closures, which was first adopted by China authorities, was then main use worldwide. Of course, it paralyzed the economy, and lots of paper were talking about the collapse or the big collapse. Vulnerable population are the most affected in the north and in the south. To take the example of Africa, we have estimation of 60 to 90% of workers in the informal sector, according to World Bank. And we will show how they are particularly vulnerable population during epidemic outbreaks. Next, please. So they are medically and socially vulnerable. I described a little bit some characteristics, but of course they have less access to care. They are in contact with many people for their activities because they have to go to see people. They are living in informal urban settlements, and they have no regular income, and they are at risk of being arrested. And we've seen that also during COVID-19. In this category of informal worker, migrants are the most vulnerable. We can talk about intersectionalities with stigma, discrimination, and exclusion. So it has been illustrated by field investigations here in Dakar with informal worker from March to September 2020. And we met mainly West African migrants. Next. So in Africa, we've seen various public health measures against COVID-19 and population reaction in Africa. I choose these 2 pictures actually to show you what Senegal is not, because contrary to South Africa, we didn't have general confinement of the populations. It's the same for all the West African countries. And I illustrate on the right the frequent riots that we've seen in Conakry, Guinea, in part because of COVID-19's measures. And in Senegal, we didn't experience that. Next, please. So I made a short chronology of the public health measures that have been taken in Senegal and their impact for vulnerable population. So as soon as we had the first COVID-19 cases in Senegal in March 2020, the emergency state had been declared, and also a curfew. We've seen movement restriction and stay-at-home measures, but it was advised measures, not compulsory measures. Then we've seen a curfew reductions 2 times, and right now we have no more curfew. Even if we see 10,000 people arrested in July because they were not wearing masks. But in August, we came back a little bit because we had new movement restriction targeting public places. And on these public places, it's where lots of informal workers are used to go. And in September, we are still in the stay-at-home measures. We know that this movement restriction impacts the economy, and particularly the informal sectors. To show that, for instance, street vendors or street restaurants were forced to close in March. We've seen also interregional and international transportation, which was blocked, with lots of impact on agricultural products, meaning you couldn't go out of Dakar, for instance, or on the contrary. We have to know that in Senegal, poverty line was 37.8% before COVID-19. And right now, we have studies of the African Economic Research Consortium who estimate that in Senegal, 2.6 million of people impoverished with COVID-19, meaning that right now we have reached the number of 55% of poor people. Next, please. So just to illustrate some informal settlements in Dakar, where street vendors live and where we have done our investigations. Next. So we've seen everywhere, and like in West Africa, lots of assistance plan, what is called the shielding activities. For formal economy, we've seen financial support with recorded amounts. For instance, BCAO, which is a West African bank of the West African state, sorry, which inject 1,400 billions of francs CFA in March 2020. So it's 2.5 billions of dollars, which is quite much. For vulnerable population, mainly food aid distributions as occur in West Africa. For instance, in Senegal, there have been a national campaign to reach 1 million households for a cost of 54 billions, which make 97 millions of US dollars. So you see on the right pictures, what they call here emergency kits for the poorest community, where you have basic foods and also soap. Next, please. Our investigation shows that informal vendors are on the margin of assistance plan, despite their high vulnerability. Of course, the difficulty is that they have no official recognitions. So we've seen that migrants, they were not the beneficiary of food aid distribution here in Senegal. And when we investigate a little bit, it's the reason is because they are not on the national register, which is called here the RNU. It's of course highlights the inequalities in inequalities, because West African migrants are not identified as poor households. I call here this invisible, vulnerable, which highlights also the hole in the social net of COVID-19 response. And of course, it amplifies outbreak impact, because this population have very few support. And even for institutions of United Nations specialized on migration, like the IOM is targeting what they call vulnerable migrants, meaning migrants who are in transit centers, which represent 3,000 people in Senegal, whereas you have 3.5 million of Guinean migrants, for instance, in Senegal. Next, please. So dynamic of resilience now. Resilience is a really interesting approach to distinguish three levels: the individual, the community, and system one. The WHO underlines 4 capacities in resilience: absorptive, adaptive, anticipatory, and transformative. Our investigation in Dakar illustrates 2 of these capacities, adaptive and transformative. Next, please. So I will go quite quickly because time is running out, but these two case studies illustrate the fact that, of course, migrants in informal sector can adapt themselves to a new context. For them, COVID-19 is a new crisis, but it's not the crisis because they have to face many difficulties. That's why we are talking about resilience. But for instance, they can change the products that they're selling, or they can change the service, etc., etc. But what we've seen is that their adaptive resilience is here. Next, please. And for transformative capacity, so we've seen that a little bit less than the adaptative capacity, but on this example, we've seen a worker of street vendors who in the middle of COVID-19 crisis managed to find a job in informal sectors really quick. I mean, so quickly with after experiencing lots of problems with his informal businesses. So it illustrates the transformative capacity. Next, please. And so to conclude, I'm 11, so I'm quite fine. Of course, socio-economic impact of COVID-19 is a crisis of unprecedented magnitude with social inequalities and also social inequalities among vulnerable people. However, it's a crisis in a structural crisis context, particularly in Africa. Migrant workers of informal sectors are at risk, even if they do not have another choice of being resilient. As we've seen, they have no access to social safety net. Some opportunity for resilience is down, but we need to question what happened in rural areas because it seems that there are less opportunities. So to conclude, social scientists' contribution is needed to better identify and assess vulnerability at all levels. It's what we try to do in this presentation, but also participate to the definition and adaptation of resilience program with the communities in West Africa. Thanks a lot. Thank you.
Thanks, Anthony. A very, again, very interesting presentation. Phaik Yeong, can I hand over to you, please?
Yeah, thank you, Chris. Can you hear me and see me all right?
I can at least.
Okay,
yes.
All right. Hi, everyone. So good afternoon, good evening, good morning, everyone. My name is Phaik Yeong Cheah from the Mahidol Oxford Tropical Medicine Research Unit based in Bangkok. So I'm presenting this work on behalf of a large team of researchers in Thailand, Malaysia, UK, Italy, and Slovenia. This presentation is about a COVID survey in these 5 countries. Next slide, please. The objective of our survey, of our study, is to understand the economic and social impacts of public health measures on these different social groups in these 5 countries. We also looked at how communication and engagement is perceived. It was a mixed method study, a survey and qualitative interviews. But this talk is only about the survey. We are currently still analyzing the qualitative part of the study. We conducted this work between May and June 2020. As the sampling method was a snowball method, we did not attempt to get a nationally representative survey, but we aimed to compare different population segments within these countries. For the analysis, we weighted the data using age, weight, and gender. Next slide, please. In total, we obtained 5,058 adult respondents from participating countries, and the numbers are shown on this slide. Next slide, please. And here are the results. So this slide shows the economic impact of COVID. If you look at the first bar of all the 4 clusters, the first bar represents Thailand, if you're not familiar with the flag. So it looks like the most affected country economically was Thailand, while the least affected one was Slovenia, which is the last bar. As shown on this graph, Thailand had substantially more loss of job and loss of earnings than other countries. Malaysia, if you look at the second half, Malaysia is the second bar. It has the highest reduction of working hours and closure of workplace. So both Malaysia and Thailand are middle income countries. So Thailand has a huge informal economy. Many do not have fixed income, such as those working as street vendors. As you know, Thailand is a very popular tourism destination with 15% of its GDP from tourism. Next slide, please. So this slide shows the Oxford Government Responder Tracker tool. This tool tracks government policies and interventions from 180 countries on standardized indicators, and it integrates the data into a stringency index for each country. The scale is 1 to 100. If you look at on the y-axis, 0 indicates very, very relaxed, and 100 indicates very, very strict response. If you look at Thailand, for instance, it's in dark blue. It has quite a high government stringency index during the period of the study. So that included closure of borders, businesses, and nighttime curfew. So high stringency index means stricter public health measures. If you look at Slovenia, it was quite relaxed, and that's the light blue, the bottom line. Next slide, please. So this slide just shows some images of Thailand. For those of you who are familiar with Thailand, you'll know that we're famous for markets and massage and all that. A strict government response index meant that many people who work in tourism, markets, massage parlors, hotels, boxing stadiums, and restaurants did not have work and did not get paid. Next slide, please. And this slide shows factors associated with worse economic outcomes. This chart shows the percentage of those who responded yes when asked if they had loss of earnings or loss of jobs. Please look at the chart from the left to right. On the left-hand most is gender, but I will not talk too much about the gender analysis because a detailed gender analysis is underway. Now focus on the second, from the set of bars from the second group onwards, so education onwards. Okay, well, from left to right. So overall, you can see that lower education levels, so P and S means primary and secondary education. Primary education and secondary education versus tertiary education. So overall, lower education levels are associated with higher impact on economy, being 65 or older, larger households, having children under 18 in the household, and having flexible income. These were the factors associated with worse economic impacts. This confirms that those who are already disadvantaged in society are worse off during COVID. Next slide, please. So this slide shows the social impacts of COVID. Starting from the left quadrant, when asked which areas of social life they are concerned about, overall 64% said social life, 59% said physical health, and 58% mental health and well-being. If you look at the top right quadrant, and these are some of the differences between countries, we found that Thai respondents were concerned about their caring responsibilities, most of all. Malaysian religious and spirituality concerns. Slovenians were worried about recreational concerns. Now moving on to the bottom left, we asked respondents how many days they could cope without going out. So without going out except only for essential needs or work. The response ranged from 1 day to 29 days. So 44% said they could cope with 49 days or more without going out. But coping time varied between countries. If you look on the bottom right, in the UK, 60% said they could cope for 29 days or longer, whereas only 26 days for Thai respondents. Next slide, please. Now, next we looked at compliance with public health measures and behavior change. Compliance and behavioral change seem to differ between countries. For example, respondents in Thailand indicated significantly higher levels of compliance, acceptance of public health measures, and voluntary behaviors compared to other countries. 9 out of 10 changed their behavior in Thailand, even before government mandated measures, whereas only 1 in 2 respondents from Italy and Slovenia. And this included wearing masks, using hand sanitizers, avoiding physical contact with others, avoiding crowded areas, and so on. Next slide, please. So in Thailand, at least, we weren't surprised with the mask wearing, as many pharmacies were already out of masks as soon as the local infections were reported. Next slide, please. In addition, in the beginning of 2020, there was quite a lot of air pollution in Thailand due to agricultural burning and other things, hence mask wearing was already a norm. Thailand also showed the highest level of compliance and agreement with public health measures. Overall, self-reported compliance with government-enforced public health measures was slightly higher in respondents with high understanding of COVID. So although our survey was unable to implicate causality, it may shed light on why Thailand has the lowest number of COVID cases in relation to its population size. Next slide, please. So we also asked, have you come across news about COVID, the following COVID topics that seem fake to you? This was interesting too. So the most striking was coronavirus was an engineered modified virus. If you see the column on the first column in light blue on the left side, so that's the percentages to look at now. If you look at Italy, 4 in 5 reported seeing fake news about coronavirus as an engineered virus. Many respondents in Malaysia, UK, and Italy said that too, whereas only 32% in Thailand. Next slide, please. Right, I'm going to skip through this. Next slide, please. Next slide, please. Okay, so I'm going to just jump to the conclusion here and summarize now. So our findings identified specific groups of people as potential target audiences for COVID communication and engagement strategies, as shown in the news about the fake news section. We also confirmed that reports of misinformation and COVID infodemic is quite widespread. So we think a lot more efforts can be made to curb this misinformation, taking into account the different groups. We also note that non-pharmaceutical interventions such as lockdown and social distancing measures to mitigate transmission of COVID exert substantial economic and social impacts on the society. We also confirm that these measures have uneven impact on different countries and different social groups. It provides an indication on which social groups need the most support during pandemics, so that existing social inequalities are not perpetuated and made worse through the introduction of public health measures. So lastly, in order to mitigate the impacts of COVID, I think we really need effective communication and community engagement. So as this is an online survey, we have the usual survey limitations. That's why in this study, we have built in a qualitative component. We have completed about 80 interviews and stay tuned for results of the qualitative study, which is coming out quite soon. Next, please. And that's it. Thank you very much. Next, please. Thank you. Over to you, Chris.
Okay, thank you, Phaik Yeong. Thanks again to Gustavo and Anthony. Yeah, I think I'm going to move to questions now. My first comment, I guess, would be that, we've had presenters from very different outbreak and response contexts. And my, I think, takeaway message was how, the informal people working in the informal economy and working in and living in informal settlements are those that have been most greatly impacted both by the epidemic and the response, and also, as Gustavo highlighted and Anthony highlighted, that they're also left behind in terms of the information that's collected about its impact. So I'd like to open the floor up for questions. Please raise your hand or put it in the chat if you'd like to put something to a particular speaker or a question in general for all three speakers. Maybe the speakers also have questions for one another.
I have a question.
Please go ahead.
Okay, her name is Naga. Maybe I should ask Phaik Yeong since she's in the same country as I am. I come from the corporate sector, and the reason when I saw this social economic impact, the big thing that's staring at me is once and when a suitable, or whatever word you guys call it, a vaccine is available, will this whole COVID-19 scenario of the environment change because there is an availability of a vaccine? Will things change for the better? Or will, even with a vaccine, you need some time before things can get back to the, people call it new normal. I prefer to use the word normal.
So that's a question for me?
Yeah, yes. If you, since you are involved in research and vaccine stuff, once the introduction of a vaccine, whether it's one from this part of the region or from somewhere from another part of the world, and it's an effective vaccine,
yeah.
How long will this whole situation change to become to something of normal, like pre-January 2020?
That's a very difficult question, Naga. I think there will be a long time. So in terms of vaccine development, there are lots of vaccines in development, and there are lots of people working in vaccines. However, there's only a couple which has gone through quite a mature stage of development. Mm-hmm. And even if they have been proven, or they are proven to be safe and effective, there's still a period where there's a lot of issues to work out on. For example, manufacturing, making sure that we can manufacture at scale, getting the right final product to countries and etc. So the point is that there's no drug that is widely available for COVID. There's no vaccines that's widely available for COVID. We rely a lot on these so-called non-pharmaceutical interventions, like lockdowns, like social distancing, like contact tracing. But what we're trying to say here is that these lockdowns have social and economic impacts on people. So governments are really finding it difficult to balance between keeping the numbers low, very, very low, and the negative impacts on the economy and other aspects of life.
So you're saying is there's actually, we do not know when, like they say, a vaccine that can cure all and things become normal. We do not have, in the foreseeable future, there's not a light at the end of the tunnel. Is that what am I hearing?
Other people, please jump in. I'm not saying that. I'm saying that it takes.
Just a guy, a private citizen or a corporate guy looking at this. No, I understand where you're coming from. Another thing that has been, because I'm involved in this whole trying to help the organization, and as I was running through, how come this particular virus? We have gone through so many pandemic and so many different viruses in the last 25 years of our life. But how come this one has given as such an impact on the global world? I'm just trying to figure out why is that we could not treat it the same way as all the other, the H1N1, the Ebola and everything else was there. Everything that was, we came back to normal. But this one is just like, you're not going to see the light at the end of the tunnel. Somehow or other, it's like, we just have to wait and see. Everybody tells you, just wait, just wait.
Thanks for your comment, Naga. I think there are obviously lots of work being undertaken at the moment to understand what, the characteristics of the virus and why it acts in the way it does in terms of its infectiousness, and then also its impacts on interactions with other underlying conditions, and why it's particularly dangerous for particular types of people in particular groups. Any other questions that people would like to put to our speakers?
Chris, Gustavo speaking.
Please, Gustavo, go ahead.
No, just a brief comment about this question. It's a more provocative response. So can we say that what we are living in the last decades, it's a normal life? When in this kind of unequal world that children, people are dying from poverty and unequal health systems and unfair wealth distribution around the world, and in the kind of world that we are living a kind of warming. So it's just a provocative, because what is the new normal and what was the normal? And vaccine, I think that in this a critical situation, all of us would like to have a vaccine now. But as we lived it during Zika outbreak, when Zika disappeared, people who lived with Zika consented syndrome and their families disappeared as well. We are now less than 30% of the children under early stimulation and health services access to specialization as neurological specialists. So just to say some words about how inequality and social inequality base a lot of impacts in this world. So just to a brief comment.
Yeah, thanks, Gustavo. I thought Anthony's summed it up quite nicely for the people who he works with. He described it was a new crisis, but not the crisis, right? I see there's a couple of questions, and Atib had a hand up. Atib, do you have a question that you'd like to ask?
Hi, thank you, Chris. Yeah, hi, this is Atib. I'm a fellow at the Bragg James Wigan School of Public Health. I had a specific question. What sort of ramifications may COVID-19 pandemic have had on the non-COVID-19 patients? Do you think that these ramifications are special than the other? And if yes, what sort of presumably may they be?
Someone would like to pick that up? Anthony?
Yeah, you mean the impact on the other epidemics, for instance, or?
Yeah, if it has had a special ramification on the people living with non-COVID-19 illnesses, those who already exist, the debilitating diseases or pre-existing morbidities. Thank you.
Definitely here, I mean, I didn't study that, but we've seen some report on that. And of course, the fact that all the health structures are focused on COVID-19 epidemics leads for the other people, for instance, living with chronic disease, to encounter some problem. So we've seen, for instance, here people living with HIV who are on antiretroviral treatments. Some of them couldn't go to the health center to pick up their treatment. In other contexts, we've seen that health structures have been avoided by general population and by the people who need to go there, because they were fearing of being infected. So of course there is a deep impact on the care to the other, I mean, chronic or other disease. It's clear on that.
So just
to
add, yeah, just to add on as well. So that's in the healthcare provision setting, our healthcare service. So while I work with a huge research network, all our research studies was stopped for a few months because it's non-urgent research. But then after a few months, we thought, we got permission to restart. So a lot of malaria work, a lot of work on maternal and child health, all equally important, was stopped. So we are restarting slowly. Yeah, so that's a lot of time wasted or yeah.
Yes, just again, a very quick comment about this. The notification of people who were die at home increased a lot in Brazil, and we are trying to identify what happened with them. It was COVID or not COVID, because COVID imposes a kind of barriers to access health system in Brazil. So especially in poor regions.
Great, thanks Atib, thanks everyone. I think there's one other question from Gabriela, particularly for Anthony.
Yeah, thanks a lot. Thank you, Gabriel, for the questions. About my survey method, the first point is that I met and I follow 15 health workers since March in the district where I live. So it's a big advantage because I see these people almost not every day, but almost every day. With some of them, we made contact, as they were key informer for me. So each time there was a new event or new situation we were seeing, we were making interview, which was not so easy sometimes because, when you are a migrant here, you are always a little bit fearing about what you share of information, etc. And about the observation, of course, the same. I made a lot of observation from where I live and from the district where I live, because I am in a suburb of Dhaka where the majority of migrants, of West African migrants, are living, because it's a district where there are lots of public places. In Senegal, it's mainly, for instance, beach. So lots of street vendors are used to go there. And so I observe after where they were going, if they were not allowed to go on the beach, I shadow them, follow, and after interview, and all this work allow me to do that. And in parallel, we also have a work on the medias and on the social network, which is done at a West African level with the CRCF project. And so I use also some information of that to complete my field works. And just about the structural dimension of their vulnerable situations, it's not directly what I present, but of course it will be a part of my analysis. And I mean, about the health program capable of including them, I think national authorities here, when they identify vulnerable people, they shouldn't exclude migrants. there is no reason for that. So I think that the national authorities here, and not only in Senegal, but also in all the other West African countries, they have the means to identify first, and after to shield or to make shielding activities with these people. I mean, they are at risk. So, and also local NGOs here, which we didn't really. They have been active, but not for migrants. So it's really, I mean, invisible, vulnerable. I think that needs to be taken. Thank you.
Thanks, Anthony. I don't see any other questions in the chat. Does anyone else have any questions or comments they'd like to add? Oh, Gabriela says thank you.
Hello, can you hear me?
Yes.
Hello, this is Carlo from Thailand. Thanks to everybody for the excellent talks. I have a question for Phaik Yeong. So here in Thailand, we've seen quite an incredible success in disease control, but as you showed in your talk, quite a gigantic economic cost. Did you look at what the people felt about the specific policies, so how adequate the specific policies were in Thailand, and how this compared to other countries, and how much trust in the institutions in general participants had?
Thank you, Carlo. So I'm going to answer the question in two parts. The first part is the in-depth detailed analysis of the qualitative part of the work is still underway. So we interviewed about 25 people from various sectors to ask them about how they felt about policies, what the impacts were. So we interviewed boxers, masseurs, hairstylists. So we will present that soon. The second part of your question is that we also asked, but I didn't present it today, is how much people agreed with the policy. So there are huge economic impacts. But you know, when we asked about how many people agreed with their policies, it was over 95%, whereas only 50% or so in Italy and the UK. So Thailand, they sort of, from the survey, it looks as if people agree with the policy measures, and they agree to comply, over 90% as well. And they even changed their behavior prior to government mandated policy. But there's a huge economic toll, as I mentioned. So yeah, that's my answer. But a more detailed one will be in the qualitative work.
Thank you very much.
I think Nahitun has a question as well. Please, Nahitun, go ahead.
Yeah, hi, I'm Nahitun from BRAC-JPG. So my question was also to the last presenter. It's almost a similar question, but I was really interested to know, as you shared that Thailand comparatively has a higher compliance rate compared to other countries regarding the compliance to the social protective measures. And you also highlighted, emphasized on working on social group targeted communication strategies. Mm-hmm. So I would like to know how actually it worked in Thailand, what type of strategies they have practiced to prepare those social group targeted communication materials or strategies. If you can share some example.
Yeah, thank you. So the results, we asked people what were their preference in communication channels, and a lot of them said online, traditional media, as well as government websites. And it looks like the government is usually using those things already. So that I can't attribute causality, but that probably contributes to people's compliance and things like that. So it was, in the conclusion, it is recommended that we target specific groups, because in our study, we note that there's this, quite a high understanding in some groups and some groups with a lower understanding. I didn't have time to talk more in detail, but the groups with lower understanding were the younger people, the people with primary and secondary education, and I think older people as well. So using the communication channels that they prefer, and then we can also target the specific communities which have a lower level of education. And that would, that would enhance level of understanding, level of compliance, and level of acceptance of public health measures.
If I could add a little bit more, because we have a 4,000 workforce, and these 4,000 people in Thailand worked through the pandemic to produce masks. One of the things we found it easier in Thailand than other countries was that wearing masks was normal for them. It was very, very normal. There was no need to force people. They were willing to wear masks. And second, like what Phaik Yeong says, telling them that social distancing and cleanliness per se is the next two important things you got to do if you want to protect yourself, both at workplace. At workplace, they're very good. We get this. But our biggest problem was how can we do? So the communication part of it, we keep on communicating in all mediums possible to tell them they got to behave the same way as they behave at the workplace, the discipline they have, the social distancing, the wearing of masks, the cleanliness, personal cleanliness, washing your hands. Take it back home and do the same and behave the same way at home, because you've got parents, you've got grandparents, you've got all these groups that you've got to interact. And we can tell you that one of the success stories was throughout the 9 weeks, we had no single positive case, though we worked through the pandemic period, the highest time of pandemic in period, our people were working, producing masks. So I thought I'd just add to what Phaik Yeong just said about Thailand in particular.
Okay, thanks, Naga, for your comment. Any other questions? Okay, well, I think we're kind of running out of questions a little bit. We're also running into the next hour. I will say that we'll be posting the recording of this webinar along with the slides on the Sonar-Global website. And there's opportunity there to post additional questions in the comments section underneath that. So please feel free to do so. If anything else comes to your mind during in the future, or if you listen back to any section of the webinar. As I mentioned at the start, there are 3 other webinars already posted on there with the slides. And don't forget to register for Sonar-Global if you haven't done so already. You can also follow us on Twitter. Check out the website for other COVID-related social science resources. Thanks again to the speakers for taking time to talk to us today. We look forward to hearing more about the work in the future. And I think that's perhaps also the key point here, right? That we've had 6 months of sort of critical semi-crisis management in many countries, and now everyone is slowly coming to the realization that in many contexts this is going to be a chronic issue with long-term social and economic ramifications. So thanks again, and yeah, enjoy the rest of your day, or good night if you're in Thailand.